been lived in the shadows of public healthcare, and despite the devastating toll it takes in the global community. So with us today, we have our Honorable CSI President, Dr. Dhiman Kahali sir, and CSI Honorary Secretary, Dr. DP Sinha sir, and we are having two guest lecture, Dr. Raman Krishna Kumar sir and Dr. Avdesh Sharma sir. So I would request Dr. Dhiman Kahali sir to please address this session with his keynote speech.
Thank you, Dr. Ghosh, for your kind introduction, and respected Honorable Secretary Dr. Sinha, my good friend Dr. Devabroto Rai, our international coordinator, Vice President Dr. Ashokan, and many other friends and distinguished gathering, Dr. Sanjay Tyagi, our ex-president and just imminent past president, Dr. Roth, I can't see you if you are there. So, and all the distinguished gathering, Dr. Rakesh Yadav, Dr. Nitish Nayak, everybody who are there. So, today is a great day, as we know that today is the birthday of none other than Dr. Padmavati. She is respected by each and everybody, all the cardiologists of ourselves. And we decided, therefore, all of us unanimously, that today should be the birthday of Dr. Padmavati, celebrated as the Rheumatic Heart Day. Because, you know, this has got a great significance. This is present in our country till now to some extent. Of course, the incidence and occurrence of this disease has come down significantly in our country, but still it is present in our country. In the developed countries like US, the European countries, the Scandinavia, it is practically absent. There is no more incidence of rheumatic heart disease in those countries. So in our birthday, let us take the pledge that we will also eradicate rheumatic heart disease from our country. Because the incidence of rheumatic heart disease world over is 1.5 crore, that is 15 millions at present. This is a rough estimate, maybe more than that. Even in India alone, I think the numbers may be like that. And it is told that every year, 282,000, that's almost 3 lakh new cases are being discovered or diagnosed, and some 280,000 cases die of the disease every year. So that is a great, Achilles heel for all of us, and we have to take a pledge on this particular day. This is a very particular, very auspicious day for us, because this is the birthday of a legend like Dr. Padmavati, who has introduced the modern cardiology in our country, and she was a pioneer in this field to work for eradication and proper treatment, proper diagnosis, because, you know, under diagnosis and under perfection for treating the disease and prevention of the disease, like continuation of the penicillin prophylaxis for the requisite years, are often ignored. And that is the reason there is flourishing, disease of this nature. But unfortunately, we have also been able to largely eradicate the disease, at least to reduce the numbers. I should not tell eradicate, but where it has been eradicated in the advanced countries, we have not been able, because there is under treatment, under diagnosis, and under reduced understanding of the disease. And also we don't understand who are the people who will be affected by this disease. So just with this introduction, I again thank you all for coming on this particular day and gathering and giving your valuable time. Let us pledge that we should all work together unanimously to eradicate the disease. Long live CSI, Jen.
Dr. Samik.
Thank you, sir. Thank you, sir, for your kind introductory words, and that has set the program in pace. So I presume that Dr. Krishna Kumar still has not joined the program because of his schedule, prior schedule. So in that case, I would request Dr. Avdesh Sharma, sir, to please kindly proceed with his guest lecture. Dr. Sharma, sir, please.
Okay, thank you. Thank you and good evening to all. Thank you, Dr. Somik and Honorable CSI President Dr. Dhiman Kahali sir and Honorable Secretary Dr. Sinha sir. and all executive members who are present here, and all the audience and participants who are watching this live webinar. And definitely, it's a privilege for me to speak on such an important topic from which our country is struggling from so many years, as Dr. Dhiman Kali had already stated, that in many parts there is a lot of regional difference between the prevalence or incidence of rheumatic fever among different parts of the world. Though in southern part of the of our country, it is almost in a eradicated phase, but in northern country it is still widely prevalent. And definitely CSI is a body which can do a lot of things uh, to prevent the further new cases or further incidents regarding to this. I'm sharing my slides. I hope, Dr. Swamik, my slides are visible.
Yes, sir.
Yeah.
Please go ahead.
Yes, sir. Thank you, sir. So my today's topic of presentation is basically focused on the prevention in controlling the rheumatic heart disease. As we all are well aware that we usually faces the established cases of rheumatic valvular heart disease. So closing the valve before it narrows is the theme of my today's presentation, because we must focus on the primordial and primary prevention so that a well-established valvular heart disease will not develop. So in rheumatic heart disease or rheumatic fever, definitely prevention as the definitive intervention in rheumatic heart disease, and preventive part is at most important. And if I talk about that majority of valvular heart disease, as I had already stated, we people usually see either in our cath lab or in the operation theaters, either during percutaneous balloon mitral valvectomy procedures in our cath labs, or during different valve meant in operation theaters of rheumatic fever before the development of valvular heart disease. So definitely a cath lab disease with a primary care origin. And before starting my presentation, if I say that if I do an audience poll that in your last 10 young patients with severe rheumatic MS, how many had documented uninterrupted secondary prophylaxis before referral? So I'm pretty much sure that majority of you will answer it in a very few number. And personally, if I say, then I had definitely not seen so many cases in the stage of rheumatic fever prior to development of established valvular heart disease. Majority of the cases which I encounter in my clinical practice are having established valvular heart disease, either in the form of severe mitral stenosis or development of multivalvular lesions, which are referred from our side to surgical site for different valvular interventions. So for rheumatic heart disease, prevention is not soft public health. Definitely, it is a disease modifying cardiology, and it is now almost more than 100 years that we know about rheumatic heart disease, but still it continues to be a major problem in developing countries like ourselves. And if I talk about the burden of the disease, then the burden is still large enough to deserve a program. And definitely CSI and our old presidents or past presidents are definitely working having very sincere efforts to act on this. And if I talk about the burden, then approximately 55 million people live with RSD globally, and out of these 360,000 annual death globally. And if I talk about South Asian regions where it is widely prevalent, then approximately 14.4 million people are affected with it, and approximately more than 50% of the death, that is 58%, occur in South Asian regions. So global prevalence is 54.8. If I talk about Southeast Asia prevalence, then it is almost near to 50%. And if I talk about global death, then majority of the death part is covered by, or majority of the deaths are happening in our regions because of different regions or scenarios. So if I talk about the Indian cardiology lens, then in India, the prevalence or presentation of the disease are little bit different from Western population of rheumatic heart disease too, because rheumatic heart disease arrives too late. But in our population, majority of the young patients, it's a disease of young, because majority of adolescents, young adults, women of childbearing age have suffered from rheumatic heart disease or rheumatic fever. So lifetime morbidity begins before income security, and majority of the patient get affected with valvular heart disease because of rheumatic fever at an early age in comparison to the Western population. And there's a lot of referral bias also. The cardiologist B people often sees the child only after years of silent valve injury. Up to that time, majority of the valve damage had already been suffered when a children or child is referred to a cardiologist for proper management. And there is a lot of intervention gap also, like PTMC and valve surgery reduce the obstruction, but they do not reverse the social biology that created it. And majority of the patient, when they come to us or refer to us, they are in a stage of valve intervention, either be to PTMC or valve surgery, but we didn't see majority of the patient before development of established valvular heart disease. And there is also a program gap. India needs reliable benzathine prophylaxis, access, recall systems, school health linkage, and regional eco pathways to strengthen the program. And if I talk about different preventive strategy, then definitely the disease pathway gives us multiple point of interception, whether it is in the form of primordial prevention, which basically reflects on the social part of the disease, that is, we must educate or we must raise the socioeconomic status of the patient by different schemes like decreasing the crowding, poverty, or decreasing the incidence of group A streptococcal throat or skin infection. And it may be in the form of primary prevention when there is development of acute rheumatic fever or there is starting of silent valve damage, or it may be in the form of secondary prevention in the form of prevention of the complication of valvular heart disease when the established valvular heart disease had already been developed. So prevention is a cascade and not a slogan, and it can be divided into different parts like primordial prevention before the development of the disease, and it basically focuses on reducing the group A streptococcal infection, transmission risk, overcrowding, and improvement in the hygiene, improvement in the housing condition of a patient, and definitely screening at a school health level. The primary prevention basically focused on treat suspected or confirmed streptococcal infection early and correctly. Secondary prevention basically focused on prevention of acute rheumatic fever recurrence, because recurrence is very bad in terms of progression of the valvular heart disease or valvular heart damage, and rheumatic heart disease progression with reliable benzathine penicillin prophylaxis. And tertiary prevention is basically focused on different prevention of different complications related to development of established valvular heart disease, whether it is in the form of prevention of atrial fibrillation, cardioembolic strokes, heart failure, pregnancy, death, infective endocarditis, and reintervention and valve deterioration. So these are the different form of preventive strategies, and failure at any level shift cost and mortality downstream. So we must focus on each and every important, and early intervention or early preventive strategy is definitely is the best strategy. So we must focus more on primordial and primary prevention in the cascade of rheumatic heart disease or rheumatic fever. So primordial prevention basically, as I had already stated, begins before the sore throat, and we can improve the primordial prevention, or we can focus on primordial prevention by improving the household crowding, by improving the health hardware like water, sanitation, washing facilities, and access to primary care or upstream cardiology tools. And we can also help by different school platforms like attendance registers, health educators, by identifying sore throat referrals, or by identifying incidents of group A streptococcal sore throats in school going children. And penicillin prophylaxis recall can all live at school levels, and schools are so important focus in the primordial prevention in rheumatic heart disease. And if I talk about equity lens, then the disease is not randomly distributed. It tracks deprivation, geography, and access. As I had already stated that in many parts of the country, disease is widely prevalent, while in few parts of the country, disease is almost in a phase of eradication. So the first cardiology intervention definitely is social risk reduction. And if we are able to improve the social status or socioeconomic status of our population, or we are able to increase the basic sanitation of our population, then definitely we act on this disease at a level of primordial prevention, which is very, very much important. And if I talk about primary prevention, then definitely treat the infection before immune injury. And we must identify the cases of sore throat or impetigo skin infection in at-risk children. We must access the clinical score and test where available high-risk algorithm, and we must treat those patients who are affecting from it by appropriate penicillin or antibiotic cost per local protocol. And we must also record these cases, document the episodes, educate the family, and look for acute rheumatic fever red flags in these patients. And we must keep a record of all these incidents in our population or in our cases. So primary prevention is only as good as the biggest peripheral clinic in the referral network. And this is the real story of our country, that primary prevention though is not good, but we must focus, or we must try to improve the primary prevention in our population too. And if I talk about different pharmacological treatment related to primary prevention, then definitely we can go for penicillin B, amoxicillin, or benzathine penicillin G injection intramuscular, either thrice weekly or after a week interval of 4 weeks, are widely prevalent. And for those patients who are allergic to penicillin, then definitely narrow spectrum cephalosporins like cefalexin, cefidoxil, clindamycin, azithromycin, and clarithromycin are the options for those patients who are penicillin resistant. But we must promote the penicillin injections in this population as a primary pharmacological tool for primary prevention in majority of our cases. And after primary prevention, we must focus on secondary prevention in those patients who are already suffered from episodes of acute rheumatic fever. And for secondary prevention, penicillin prophylaxis is the penicillin injection is definitely a disease modifying therapy for the valve. And why it matters? Because each recurrent acute rheumatic fever episode in these cases can add cumulative valve injury. So penicillin prophylaxis or penicillin injection prevents recurrent streptococcal triggered acute rheumatic fever. And there is no doubt that it is low cost, proven, and system dependent, and not technology dependent. And a missed dose is a clinical event, not an administrative lapse, because patients and B people are more responsible for irregularities or missing the dose of penicillin injection in comparison to the administrative lapse. So our operational target must be that no child who has suffered from episode of acute traumatic fever should miss the benzathine penicillin prophylaxis or benzathine penicillin injection because the system forget. And the schedule must be boringly reliable. It can be given at an interval of either 28 days or 21 days. And majority of the highly endemic zones, I prefer to use 21-day schedule, that every patient who is suffering from acute rheumatic fever episodes must be given an injection of 1.2 million unit benzathine penicillin, deep intramuscular injection after proper sensitivity testing. And if the patient of less than 20 kg, then 6 units can be prescribed to these patients after every 21 days. Second line, definitely penicillin B oral 250 mg twice a day, or we can also use erythromycin 250 mg orally twice a day in these patients for prophylaxis purposes. And for how much time? So as per ACC guidelines, or as per the guidelines recommended by Cardiological Society of India also, that if there is rheumatic fever plus carditis plus residual valve disease, then 10 years or until more than 40 years, whichever is longer period. And if carditis, rheumatic fever, but no residual valve disease, then 10 years, or until more than 21 years, whichever is longer. And those patients in which there is no episode of carditis, or there is no established carditis, only rheumatic fever, 5 year or until more than 21 year, whichever is longer. So practical dosing principle, that is benzathine penicillin G intramuscular every 21 or 28 days, and 21-day schedule for high risk patient or breakthrough acute rheumatic fever per local protocol, or those which belongs to high endemic zones. And if I talk about the adherence failure of benzathine prophylaxis, then is usually a health system failure. Because if I see the cost, then approximately benzathine penicillin prophylaxis cost around 62.5 rupees monthly cost. And out of this, 50% cost is because of transport, that is hidden cost, and it costs to patient around but for 20 rupees. And there are a lot of reasons that why patient leave benzathine prophylaxis, or why they are non-adherent or non-compliant to benzathine penicillin. So definitely knowledge gap is a reason, because they are not concerned that if they miss the dose, then definitely there are more chances of recurrence, and their valve is going to damage more rapidly. So there is a knowledge gap. And drug unavailability is also an issue nowadays, because it is not frequently available in the market because of economical reasons, because companies are not getting so much profit in manufacturing these injections. And fear of pain in patients is also an important cause, which can be avoided by doing certain maneuvers. And definitely misadvised by either our colleagues or some other peoples or some family members is also an issue. When patient is advised lifelong or up to 40 years or 21 years benzathine prophylaxis, then some people misadvise these patients. That's and also a reason for non-adherent to benzathine penicillin. And affordability is also an issue, especially in our country. So we must fix the system defects by recalling these patients, by if possible, then by doorstep delivery of the injections, and by operating or by adopting different pain protocol mechanism. Stock visibility, we must have a visibility on stock, patient education, and registry alerts. So we by taking these steps, we can improve the adherence to benzathine penicillin in our patients. And if for secondary prevention, definitely benzathine penicillin is the first option. And despite of this, we can also use benzathine penicillin B, sulfonamides, and erythromycin as a oral drugs, those who are not able to take intramuscular injections. So if a patient take intramuscular benzathine prophylaxis injection, then the chances of echo detected latent RSD at 2 years is only 0.8%, while those who are not taking prophylaxis, it is almost so much high, that is approximately 10 times, that is 8.3%. And number needed to treat are 13 over 2 years to prevent one progression of events. So definitely benzathine penicillin is an important tool for further to prevent the further damage of valvular valve in these patients. And echocardiography changes rheumatic heart disease from late diagnosis to active case finding. And by focusing on WHO 2023 guidelines, that echo is not only a diagnostic luxury, but in endemic settings, it is the gateway to secondary prevention. And majority of the patient must also undergo echo screening. So screening is useful only if it is tied to a care pathway, that it must be done at risk school, in at risk population in schools or community, that in age 5 to 20 years with high burden geography. And basically handheld or focused echo can be done as a screening tool, and confirmatory echo can be done by in a selected population, for those who fits in screening echo by cardiologist or expert review. Then according to on echo finding, we can risk stratify these patients in different groups, and based on the echo findings and other parameters, we can make a registry for benzathine prophylaxis and follow up of these patients. So do not screen without the ability to recall, confirm, and counsel or start prophylaxis and follow. So it's our moral duty that once we screen a patient, then we must focus on proper adherence to benzathine prophylaxis by recalling, confirming, counseling of these patients, and we must keep the proper follow-up of these patients. So a school-based RSD program is a logistic program. It seems to be a logistic in our country. And there are different schemes like Rashtriya Bal Suraksha Yojana or at PSC level, and then echo can be done at a district echo hub. Then these patient can be referred, selected patient can be referred to a cardiology center, and we can make a digital registry of these patients. So case finding, prophylaxis delivery, confirmation, escalation, and retention of these patients by SMS, WhatsApp recall, plus missed dose escalation or family counseling is very important to reduce the burden of this disease in our country. And if I talk about tertiary prevention, which is mainly focused on the prevention of the complication because of established rheumatic heart disease, then these tertiary prevention do not let established rheumatic heart disease become preventable catastrophe. And we must have a valve surveillance regularly of these patients by serial echo, lesion severity, pulmonary pressure assessment, LA size, RV function, and we must define the intervention timing in these patients, whether percutaneous or whether surgical. And AF and embolism, warfarin, BK based stroke prevention in rheumatic atrial fibrillation must be advocated, and proper or serial INR monitoring must be done in these patients. And if patient is in a state of heart failure, then proper treatment and management must be given to these patients, and post intervention care must be properly followed in these patients. So the valve lab prevents obstruction, and the longitudinal clinical prevents the diaster. So RSD prevention is also maternal cardiovascular prevention, because in our country or in our population, rheumatic MS often declares itself during the pregnancy, and severe MS first diagnosed as antenatal booking in majority of the patient, those who are not aware with this disease. So AF, pulmonary hypertension, and heart failure carry maternal fetal risk, and preconception intervention is safer than emergency precision in these pregnancies, and secondary prophylaxis remains a reproductive age safety intervention. So the best opportunity is to detect these patients at an early stage during their schooling age. Then we start proper prophylaxis, and preconception risk assessment must be there. Then elective PTMC or surgery, whichever is feasible, must be indicated to these patients. And the cardiologist role must move upstream. We must be at a higher level in every step, and we must be, and cardiologist must be a protocol owner for local benzathine prophylaxis pathway, eco staging. He must be a quality controller, must be a trainer, and he must advocate drug procurement, emergency kits, pain control protocols, and valve specialist that timely PTMC or surgery, post-procedure prophylaxis continuity. These all must be observed and monitored personally by a cardiologist in this series or while managing these patients. So a high volume valve center should be a regional RSD prevention command center, and missed prevention becomes costly rescue medicine, because the earlier the interception, the lower the cost and smaller the patient level burden. That's why primordial and primary prevention carries great importance in comparison to secondary and tertiary prevention. So early prevention from patient's point of view, if I talk, then what does early prevention buy? It buy low burden, that lower direct cost, fewer admissions, fewer procedures, safer life, that fewer complication related to valvular heart disease like AF, heart failure, pulmonary hypertension, less pregnancy risk, easier treatment by oral or IM antibiotics, planned follow-up, better quality of life. So prevention is not only cheaper for the system, it is lighter treatment, fewer complication, and better life years for the patient. And economically, prevention is the structural heart program which India can afford, and Lancet Global Health Modeling combines secondary plus tertiary prevention control studies, and it defined that they are cost effective, but equity requires delivery system that reach high risk communities. So definitely benzathine penicillin prophylaxis is a low unit cost, high system dependence, followed by eco screening plus registry, which carries a moderate cost with high coordination value, and then ultimately PTMC or surgery of these valves, which is high cost or late rescue. So if we intervene at an early stage, then definitely the procedure or everything will be less costlier or cheaper. And a practical Indian implementation model, if I talk, then definitely at a level of village and school, we must go for sore throat flag, health education, and screening consent. either at the school level or at the society level. Then at sub-center or PSC, we must focus on proper benzathine prophylaxis delivery. We must focus on proper maintenance of stock log. Adverse event kit must be present there, and people are properly counseled how they will handle the adverse event related to benzathine prophylaxis. And missed dose call must be given to the patient so that proper adherence can be maintained. At district hospital, confirmatory echo can be done, stage classification and a registry audit can be made. And at medical college or valve center level, complex echocardiography can be done by expert cardiologist. And if any intervention required in the form of percutaneous or surgical, then it can be done. Or there must be a proper pregnancy clinic that is dedicated to those who are suffering from rheumatic heart disease. So definitely we must design the principle, but put injections near the child, put eco expertise near the districts, put accountability at the state level. So the registry is the intervention that remembers, and we must focus on more than 80% on the time benzathine prophylaxis doses, and anything less is not a prophylaxis program, and definitely it is only a sporadic treatment. So our focus must be on proper supply of benzathine penicillin and proper adherence and compliance of benzathine penicillin prophylaxis to those who have already suffered from acute rheumatic fever. So what should a prevention program measures? Definitely is measures the proper coverage, confirmation, prophylaxis, adherence, safety. We must focus on safety issues also and outcome. So screening volume is 20, on-time prophylaxis and prevented progression are the real endpoints. And at last, the 5 important take-home messages of my today's presentation relating to the prevention or screening part of valvular heart disease or rheumatic heart disease is basically that rheumatic heart disease is preventable valve disease, and severe valvular heart disease is a late system failure. And benzathine penicillin prophylaxis is disease modifying therapy, not a pediatric footnote. We must focus on this. And echo screening is justified only when it fills a registry and prophylaxis pathway. And echo screening definitely helps a lot to identify the patient at an early stage before the development of established valvular heart disease. And interventional cardiologists should own downstream quality and upstream accountability. We must take more accountability on the prevention of rheumatic heart disease in our country. And India needs RSD prevention pathways, not only more valve rescue capacity, that we must not focus on more on intervention related to PTMC or valve surgery, but we must focus on primordial and primary prevention in these patients. So we must build the prevention pathway before the next valve camp, and every cath lab RSD patient should trigger a question: which child in that blaze or area can still be kept out of this lab? Thanks for kind listening. Thank you all.
Thank you, sir. Thank you very much, Dr. Abdesh Sharma, sir, for your detailed deliberation on this topic. And I'm very delighted to announce that Dr. Krishna Kumar, sir, is also with us. He is online and has joined. And I would now request him to please take and give some insights on this World RHD Day. Over to you, sir. Sir, you're muted. You're muted. You're muted.
Thank you, Soumik. Can you hear me
Yes,
now?
sir. Yes, sir. Sure.
Yes, we can hear you.
My sincere apologies. There were some scheduling issues here. Now, I just wanted to firstly congratulate CSI on this initiative. This is, I think, probably 40 years overdue, as much overdue as CSI is in its age. It should have been done. We should have had this clear focus on RHD long ago as a responsible member of the Indian health fraternity. Now, foundationally, I think the previous talk was exceptional in the sense that it laid out the whole framework very well. It provided the an extraordinary summary of the knowledge base that we all need to have as cardiologists. But the problem really is not that we don't know. We knew this. We knew this all along for the last 40, 50 years, but we don't do anything about it. Now, why is it that there is such a no-do gap? between what we knew about RHD and what we've done to prevent it or even treat or even provide equitable access to our patients. Because of system failures, because of widespread system, we need not beat ourselves alone, but there is an extraordinary level of failures within our health systems at all levels that has resulted in this extraordinary neglect of rheumatic heart disease. And there are lots of challenges we have to acknowledge. In India, it's very diverse. Where I am in Kerala, RHD has almost gone away. But if you look at not just Kerala, but if you look at Goa, if you look at many other parts of the country that have good human development indices, RHD has declined very dramatically. But it remains extremely prevalent in those parts of the country that have poor primary access to primary care. This is exactly the situation anywhere in the world. And where there is the maximum RHD burden, there are no cardiologists. See, what we do as cardiologists is dictated by market forces. Where we choose to live, where we want to send our children to school, is all dictated by where we want to live. So our practice is entirely governed by market forces, and we are essentially, dictated by that. Now, under these circumstances, how are we going to reignite the interests of cardiologists in a disease that affects the poorest? We need a different approach. We need a societal remediation on this whole process. We need a healthcare that's regulated and that is aligned with societal priorities. It has to happen at a very fundamental level. If we are the change makers, that would be amazing. At least some of us need to do that, we need to get out of our ivory towers, start communicating with policymakers, start doing something for primary prophylaxis, start acquiring an understanding of public health, look at our own specialty with the public health lens. Then we could start seeing and making those changes. I've seen that it's not just in India, it's globally. Cardiologists are just not interested in rheumatic heart disease. Today, if I take classes, it's so different from what it was when I was a DM student. Nobody knows, but nobody actually cares. It's all they want to do is to get through their exam by understanding how to take care of multivalvular heart disease. But they're not going to go out of the extra mile and secure an access and make sure that a poor patient gets a PTMC. It's not going to happen under the pressures in which we all function in. So it needs an extraordinary level of policy level mediation. At least some of us can then become accountable. And at least some of our medical colleges can become centers of excellence for RHD management. And there are many government medical colleges that are doing a stellar job of providing surgeries and doing interventions in large numbers. But there needs to be so much more, especially in those areas that are particularly worst affected, where there isn't much access to good tertiary healthcare. So we need to make the changes, and CSI can be the instrument of change. CSI must be the instrument of change, and that will just lift the credibility of CSI to an extraordinary level. So with this, I really think it's a great initiative that CSI has taken. Thank you, Soumik, for really leading the light and taking this on and doing this function. It's really important that this day could earmark a real new beginning in our CSI chapter of, and where we can actually take on the social responsibility of making a difference to lives of the poorest in this country. Thank you.
Thank you, sir, for the enlightening words. I would just to inform you that CSI has been in this pathway, and previous year also we had this program with the previous convener, Dr. Sutra, and but the policies have not been streamlined yet. And I am very optimistic that I would in these 2 years make two things, at least a registry and a consensus statement regarding RHD in India. So this is my thought. And I would also like to take opinion from the other panelists. I see Dr. Prakash Mandal, sir. He is with us online. Sir, if you can share your thoughts regarding today's topic.
Good afternoon, everyone. I think my voice will be a bit cloudy because I am in a remote place, because I'm in my native
Sir, you're very
place.
clear. You're very clear.
Okay. Thank you. I think nationwide, our prevalence is also a bit not uniform. It is northeast states, and Bihar has got very high incidences and prevalence. And so far, I can remember in the last 1 year, whatever PTMC I have done, 90% of them are from Northeast. And Northeast countries like Meghalaya and Manipur, they have got the very high incidence still now and prevalence also. So I think if we want to make something different in your registry, you have to focus on Northeast also, because that Northeast area and a CSI member of those areas, they should cooperate with us so that we can form a good registry and we can come out with some preventive program that can be handed over to the local government also, because without help of the local authorities, particularly in the district level or rural health center level, unless they are also get involved in the preventive program. Dr. Sharma has highlighted nicely that this benzathine penicillin prophylaxis program, that to be stressed. And there was a word of sledgehammer approach that is also with this prevention and programs. I think that to be readdressed in some of the states where the incidence is still increasing or it is not going down and prevalence is also very high. So we must formulate a registry and come out with some suggestion that can be handed over to the national government or state government to implement, at least at the rural health center level. And most of the schools should get involved also. I think Dr. Devbrata is also very experienced in this field, that at the school level, we should communicate something that how to screen them and what are the things we can cooperate with them as a preventive program. Because unless we are going to the root, whatever we are discussing here, that will not be so much effective. So school programs should be with us. And some of the areas that to be focused, another area, pre-pregnancy screening for rheumatic heart disease. That area also to be addressed, because pregnancy outcome due with a rheumatic heart disease is also very bad. And some of the BMBs we are doing during pregnancy is also not so good. It is not too easy to do, and outcome is also not good. With these few words, I should stop here, and anything else that can be discussed now also.
Okay.
So, yes, sir, Sinha, sir. Yeah.
Yeah, we have some senior members with us. Today, Dr. Arvind Kumar. Dr. Arvind Kumar, are you online? Dr. Arvind Kumar. Dr. Arvind Kumar. Would like
I have joined very late, sir. I was stuck in my cath lab, so I joined very late. But my opinion is that I agree with Dr. Mondal. We should include all school. We should have a school program, because an adult we are doing only. We are not seeing the rheumatic fever cases. We are just patient comes to us for BMV, for mitral stenosis. So we should screen for the incidence of rheumatic fever in the school age group. That is my suggestion.
Thank you. Thank you, Dr. Kumar. Dr. Meena. Dr. Chandravan Meena. Dr. Meena, are you there? Dr. Meena, are you there? I think. Yes, kind of right. Dr. Rai, you would like to?
Yeah, I think Shomik will do a very great job as the convener of the Rheumatic Heart Disease Council of CSI. Over last few years, CSI is considering rheumatic heart disease as a very serious issue, and we have started several programs, and I hope it will result in some great outcomes in the immediate future.
Thank you. Chandravan Meena, can we have some?
Yes, sir. Good afternoon, everybody. Actually, I'm a there may be some disturbance on the network. But I think as everybody understands, the school has education can also be one part of this. If we can include something in the school education, apart from the preventive in the school health, I think that will make a significant change in the prevention of rheumatic heart disease.
Thank you, sir, for your insight.
Okay, thank you.
Flight is flying. After 1 minute is flight.
One thing, Dr. Sharma, can I ask you one question? That can we take the eco screening as a screening tool in the school level? Is that
Yes,
possible
sir,
thought or?
definitely. Yes, sir, definitely. I had stated in my presentation that those echocardiographer who are at basic level, who have a basic training in echocardiography, like at MBBS level or just those primary persons, those who are posted at primary health center, can do a screening echo, and if they found something extraordinary or they found something correlated with the occurrence of rheumatic heart disease in these patients, then these patients can be referred to a higher center, to a cardiologist, because as a cardiologist we usually see these patients at a very late stages.
Okay.
Can one comment when we make that say all fever patient attending to a primary health center, they should undergo a screening for rheumatic heart disease, rheumatic fever? Eco wise, is that possible also? All fever patient attending to a primary health center, because unless we think something else, that all fever patient coming to a primary health center, they should be segregated, and the doctor there said to be requested that you should go for a screening. Is that possible? Otherwise, we cannot catch them.
But sir, so frequently echocardiographers and echo machines are not available. That's a practical reality.
That's a practical thing.
And especially at periphery, the echo machines are still not available in our country. So definitely. And
Okay.
persons, those who can do such a even such screening echo, they are not available at primary health center or even at community health centers.
Yeah.
So we must focus more on clinical parameters in comparison to echo parameters. And though many eminent cardiologists, including Dr. Vijay Lakshmi and all those, had already stated different criteria for early screening echo diagnosis of rheumatic fever or rheumatic heart disease. But in practical sense, because of unavailability of echo machines and unavailability of cardiologists or physicians, those who can do screening echo, that's an issue, sir.
Dr. Sharma,
Yes,
you
sir.
have given a very nice lecture, Dr. Kahal here. So, regarding your primordial prevention, which is very important, I think.
Yes, sir.
You jot up some of the points you have given very nicely and send it to us, or we can have another Zoom meeting to discuss about it so that we can propagate those ideas. I don't know how far practical it will be, but at least let us try for it. I think Dr. Devdattu and Dr. Sinha are also there, Dr. Mondal is also there, with Somin being in the charge of the Rheumatic Council. We can think about it so that we can give at least some more coverage from the Cardiological Society of India point of view.
So basically, primordial coverage and improvement in the socio-economic status and housing condition.
That's
That's also basically government part, and we can give suggestion to the government authorities in relation to this.
Yeah, so we have to give some practical points because all
Yes,
of a
sir.
sudden it's not possible to change the socio-economic structure with a population of 1.45 billion. It's very easy to talk, but it's very difficult to implement.
Yes, sir.
So can you jot down, you are a very experienced professor, and with your colleagues, that what way we can go, because you have a huge expertise of treating huge number of rheumatic heart disease. In private sector, we don't get that much of rheumatic heart disease. So you can get patients, you can screen them. So can you come with something positive in the field of primordial and primary prevention? Because from CSI point of view, we can go ahead and do something about not possibly eradication total, but to some extent we can reduce the quantity or quantum of the disease.
Yes.
So
We can think over it, and we can again rejoin another day planning it. And for the past 1 hour, we have got a brilliant discussion of how to eradicate RHD at least by 2030, if at all, in India, because in some states it's already eradicated and in some states it's prevalent. So I would now welcome Dr. D.P. Sinha sir to kindly address this session and give his closing remarks. To you, sir.
Thank you, Swami, for conducting an excellent program. As we come to the conclusion of today's observations of Rheumatic Heart Disease Day it is my privilege and honor to put the vote of thanks. First, and we pay our heartfelt homage to late Dr. S. Pandal, a legendary cardiologist, visionary teacher, and former president of CSI, whose lifelong dedication to cardiovascular health continues to inspire generations of physicians across our nations. This special day, celebrated on the occasion of her birth anniversary, reminds us of our collective responsibility to continue her mission in combating rheumatic heart disease. I'd like to express my sincere gratitude to our President, Dr. Dhiman Kahali, for his inspiring remarks, for highlighting the significance of this day. I also express my heartfelt appreciation to Dr. Abdul Sharma for his excellent presentation, and I will be happy if you can share it with the general cardiologist or with our president for onward transmission to the persons who are interested in working in the rheumatic heart disease. I thank Dr. Krishnan Kumar for giving us a hard-hitting reality check of what is happening, what has happened, and what is happening, and what's the future we are looking at, and how to get out of it. I also thank our esteemed members present, Dr. P.C. Mandar, Dr. Abdul Sharma, Dr. Chandran Meena, who took time out. Dr. D.C. Sethi has joined just now. For sparing time and giving inspiring comments. My sincere thanks goes to all executive committee members, faculty members, panelists, and participants. Finally, I would like to thank every delegate who has joined us today. Your presence reflects our shared commitments towards improving cardiovascular health and strengthening awareness about rheumatic heart disease. Let us carry forward the vision of Dr. Padmavati and continue working together. Thank you all for your participation, support, and commitment. Stay safe, stay healthy, have a pleasant evening. Jai Hind. Long live CSI.
Yes, sir. Thank you, sir.
करने के लिए कवर को हटाएं और सामने वाली के पीछे रख दें। Recording stop.